base dose calculation and in vivo dosimetry.
Assalamu alaikum wa rahmatullah. Bismillahir Rahmanir Rahim. So my topic is not the something which is the state of the art technology and the systems and the technology of today, but it's more about the conventional therapy, which is about the total body irradiation actually. But there is always room for the improvement in all the technology which we have been using so far. So what we have done in this TBI technique is how can we improve, how can we optimize this technique. So we worked on three aspects. First one is the patient setup, second one is the dose calculation based on the CT, and third one is the improvement in the in vivo dosimetry. So these are the three areas which I'm talking about. So background is that we have to optimize the techniques to have the better outcome and minimize the adverse effects. So this work develops the experience of our institute regarding how to optimize the total body irradiation technique, focusing on the patient setup intricacies, dose calculations via CT-based methods, and doing the in vivo dosimetry for the verification of the dose which we have delivered to the patient. So there have been many different techniques for the TBI. What we are doing is the bilateral irradiation. This is our patient setup. We are using SSD of 500 centimeter just along the wall, and we are using rice bolus for the composition of the tissue deficit, and we are using 1 cm per specs sheet as a beam spoiler. So what we have actually changed from the current technique is the adjustable acrylic jet to compensate for the tissue deficit at the head and neck area. So there is the acrylic sheet, simple acrylic sheet, which is adjustable in terms of the variation in the thicknesses. And here you can see the pockets. It's just a bag and has the different pockets. So one is at the head side and two are at the lateral sides, and we can put the rice into that. And the beauty of these bags is that when you do the CT actually, then you can see it's a very uniform compensation of the dose deficit, tissue deficit at the head and neck area. Similarly, we put these rice bags between the two legs, and again you can see the CT of these. It's uniformly compensating the tissue deficit. So our aim is to deliver the dose within plus minus 10%. So how can we achieve without compensating the tissue deficit? So our challenge is to how to compensate the tissue deficit across the body. So we made this jig to compensate the head and neck area, and this simple bag which comprising the rice to compensate the tissue deficit between the legs. So what we do actually, once we do the CT-based calculation, so what we do that we chose around 25 to 30 anatomical locations, landmarks, to put our dosimeters to know what is the major dose actually. So we mark these positions on the patient and then do the calculation, WED calculation, water equivalent depth calculation, to know what is the calculated dose. So these are the separations, physical separation, and these are the WED with the composition with the rice bags, and you can see the doses. So prescribed dose is 150 centigrade, and what we are getting is within plus minus 10%. If there is any change we are having with the CT, so we can intervene between the fractions as well, or before the patient treatment as well. So if it is within 10%, then we go with that. Otherwise, sometimes we repeat the CT as well. Here is the in vivo dosimetry setup which we are using. It's like Ashland system with the FilmQA Pro software and Epson LQ 11,000 scanner, and this is capchromic films, EB3 capchromic films. And we cut the films into 1 centimeter by 1.5 centimeter small pieces of capchromic films, so that we can place it easily and comfortably to the patients. And these numbers is actually reflecting the anatomical positions on the patient. Here are the results. So these red ones are the ones which are beyond the tolerance, which is 10%, plus minus 10%. And you can see there are a lot of number of dosimeters. So within one fraction, we used to have at least 25 to 30 number of dosimeters to know all across the body what is the measured dose. And you can see the doses. So here is a separation WAD prescribed dose, and these are the calculated doses. So 105, 104, 98, 95, 105, like this. So these are different anatomical locations all across the body, and there are only two locations which are beyond tolerance. But these are very close actually. So 110% and 111%. So what we then do, we like measure the intrafraction, the standard deviation between the doses, and interfraction. So interfraction and intrafraction, we both measure, and the standard deviation you can see here is within plus minus 5%. So that is the actually outcome which we have increased actually. Before it was around 6 to 7%, sometimes 8%, 9%, but now it's within plus minus 5%. So here you can see the intrafraction, which is like moving from minimum of 95 and maximum of 111, and 4% is standard deviation. And for the second fraction, for third fraction, for fourth fraction, and so on. And we also use the control chips to verify whether everything is within the right direction, is there any deviation from the control chip or not. So these are the 5 control chips which we place on the beam spirals to see the interfraction doses, is this the same or not. So, and there are 2 background chips as well, which is showing here 0.7 and 1.1. So even the interfraction control chips is within 5%, which is showing that our setup is accurate enough and our beam spiral distance is also good. So in nutshell, what we are getting is the in vivo dosimetry results, which is very well, falls very well within 5%. And these are the number of 20 patients, different patients, which is which is showing that the results have been improved with the help of patient setup, with the help of WAD calculations, which is CT based, and with the help of in vivo dosimetry. Conclusion. So collectively, this emphasizes that the significance of meticulous patient setup, accurate dose calculation based on the CT, and water equivalent depths improves our outcomes, and of course it is like give us better results of and accuracy as well. The successful integration of these elements contributed to the optimization of the TBI procedures, resulting in enhanced treatment outcomes and minimized potential or variability in delivered dose. Thank you for your attention. Any questions? Yes.
How long do you
It's 24 hours.